Today I'm going to discuss about is a very important topic that is systemic lupus erythematosus. So it is a multi-system autoimmune disorder that organ damage in this disorder is basically to the type 2 hypersensitivity reaction that is a very high yield. And the early complement deficiency also takes place in this disorder. The most common presentation of this disorder is arthritis, and most specific antibody is anti-Smith. SLEs also increase the risk of malignancy, particularly non-Hodgkin lymphoma. So it increases the risk of the malignancy, particularly the non-Hodgkin lymphoma. The criteria to diagnose the SLE is a very easy, that is a mnemonic for the dopamine rash. So the first one is a discoid ray rash, oral ulcer, or photosensitivity, arthritis, that is a symmetrical, symmetrical arthritis, malar rash, and immunological criteria, that is antibody dsDNA and anti-Smith antibody. So this anti-DNA is basically antibody that used for the follow the disease activity. So the disease is used for follow up the disease activity, and it is also used for the development of lupus nephritis. Lupus nephritis, neurological symptoms, that is a lupus cerebritis, severe elevated ESR, renal disease. So renal disease, when we're talking about the renal disease, that is a lupus nephritis. And lupus nephritis mean here diffuse proliferative, diffuse proliferative glomerulonephritis. So it is a basically the most common cause of that in the SLE patient, that is a lupus nephritis. And most important thing to follow up for the lupus nephritis is a biopsy. So severity, for the severity, you use biopsy. Lupus nephritis severity, for you need to biopsy, and follow up you need anti-DS DNA. An flare, acute flare of SLE, to which antibody is raised again, it is a dsDNA antibody, right? Okay, so diagnosis of SLE, you need to the four things from this dopamine rash. If the four things are present, it is most likely that this patient is suffer from SLE, that is a systemic lupus erythematosus. So the Libman-Sect endocarditis is basically the non-infectious vegetation, is particularly on the mitral valve. While the neonatal lupus means the neonate present with a congenital heart block, periorbital diffuse rash, transaminitis, and cytopenias at birth. So the pregnant lady who has anti anti SSA anti-SSA positive has an increased risk of neonatal lupus, right? One of the high yield thing related to the SLE is a thrombocytopenia. The thrombocytopenia again a very high yield point related to SLE, thrombocytopenia. Antiphospholipid syndrome is very common in SLE. So the criteria to diagnose the antiphospholipid syndrome, you need one clinical finding and one lab finding, right? So in clinical, we divide again into the two things. That is a vascular thrombosis, and pregnancy, recurrent pregnancy loss, right? Okay, so vascular thrombosis, it may be arterial thrombosis and it may be venous thrombosis. For lab finding, you need again one lab positive finding to diagnose the patient has antiphospholipid syndrome. The first one is a lupus anticoagulant. Lupus anticoagulant. Lupus anticoagulant may prolong the PTT. PTT. Second one is the anticardiolipin antibody. So anticardiolipin antibody may lead to false positive VDRL tests and RPR tests. So these false positive, right? So now I'm going toward the treatment of antiphospholipid syndrome in case of the pregnancy. So we give patient aspirin, pregnant patient, and heparin. So this is a treatment of SLE for the mild joint symptoms. We give NSAID. For acute exacerbation, we use corticosteroid. For the corticosteroid, hydroxychloroquine, that is anti-malarial drug, cyclophosphamide, and isotretinoin can be used for the progressive or refractory case. So hydroxychloroquine, and that is anti-malarial drug, can be used for the isolated skin and joint involvement in the systemic lupus erythematosus. So cyclophosphamide is used for severe cases of lupus nephritis. Be sure to get renal biopsy for patients with nephrotic syndrome. For the severity of the lupus nephritis, you have to take biopsy.